Thank you very much. It is 6:13 in the morning here, and I am pleased to be presenting remotely because I'm actually on the inpatient service attending at Santa Monica Hospital, and most of my patients have dementia. So let's get started. Next slide, please. So this is kind of a setup slide, and the reason I like it because of the umbrella, because dementia is the umbrella term. And as you see, the biggest drop here is Alzheimer's disease, which accounts for 60 to 80% of dementia. The others are much smaller, but they are important, particularly early in the disease when there are some kind of differential patterns of behaviors and complications. At end-stage dementia, they all pretty much have very similar kinds of complications. But it's important to recognize that during this introduction, sometimes I will be speaking about dementia as a whole, and sometimes I will be speaking about Alzheimer's disease, and pay attention to that, please. Next slide, please. So this is a huge problem. It is a huge problem, particularly for the older people. People 65 to 74, it's uncommon, although it does happen. Then it starts getting higher prevalence rates. And once you get above 85 years or older, some of the estimates say 33 to 50%, and at 95, sometimes they say 75%. And what I'd like to tell the students is that, the odds are that one of your grandparents or two of your grandparents are going to have this. And for everybody in this room, at some point or another, the likelihood is that you or your spouse will develop it, or your partner, or your brother, or your sister. It is a disease that affects everyone. Currently, 6.5 million Americans are affected. Those are the most recent data. And to put that in perspective, it is the size of Chicago and Los Angeles put together, everybody in those two cities having dementia. By 2025, not far away, 7.2 million, which is about the size of Rio de Janeiro. There are much higher rates in African Americans, about twice that of white Americans, and particularly Asian Americans, and also Latinos. Next slide, please. This is an important slide because in 2011, the NIA and the Alzheimer's Association restaged Alzheimer's and redefined it essentially into three stages. The first is normal cognition, and it's defined by changes in biomarkers. Okay, we'll get to that in just a moment. MCI is actually, there is something wrong with cognition, but it is mild enough that overall function is preserved. Once again, biomarkers may be present that help to determine either whether they progress to full dementia or differentiating Alzheimer's disease from other diseases. And finally, the third stage is impaired cognition and impaired function. And then once again, biomarkers may be helpful in excluding Alzheimer's disease as a cause. Now, this is very important because the enormous estimates of the burden on the population that I just presented, if you stage it according to biomarkers, the number of Americans in 2017 who were estimated to have positive biomarkers for Alzheimer's disease was 46.7 million. Okay. Obviously, the vast majority of those were in the preclinical or the MCI stage, but it just tells you that this train is really going to move very quickly because about 10 to 15% of people who have MCI will convert every year, and about 50% over 5 years. Next slide. The care of persons living with dementia is expensive. These are 2022 data that were just recently published. Total payments, $321 billion, about 2/3 of which come from Medicare and Medicaid. About a quarter come from out-of-pocket costs, and the rest are various other insurances. Unpaid, on top of that, unpaid caregivers, approximately 16 billion hours, accounting for $271.6 billion. And if you take a look at it at the individual level, the lifetime cost of a person living with dementia is almost $400,000. Next slide, please. And what do we get for that? Mediocre quality. This is a result of a number of studies that were conducted by Lee Jennings, summarized by Lee Jennings, where she looked at community-based physicians and the quality of care as measured using chart reviews with ACO3 and Physician Consortium for Practice Improvement Quality Indicators. And you saw that, you see that about 40% of community-based physicians, 40% of quality indicators were satisfied by community-based physicians. When you add a nurse practitioner who co-manages 5 conditions, it gets up to 60%. And if you have a nurse practitioner who, or a physician assistant who focuses solely on dementia, you bring the quality of care up to 92%. Next slide, please. So what does this disease look like? First of all, there's progression of cognitive decline. The mini-mental state examination is a test that used to be used a lot, but then became proprietary. But it's a 30-point scale, and you see that you lose about 10% per year. That's been demonstrated in numerous studies. But then there is the non-cognitive symptoms. And these are prevalence data. Apathy, about 50%, depressive symptoms, 40%, agitation or aggression, 40%, sleep disorders, 40%, and delusions, 30%. These are very disruptive symptoms. The average survival depends upon which cohort you look at, but it ranges somewhere between 3 and 12 years, which means that many people live with this disease for a long time. Next slide, please. So what do we do about dementia? This one focuses on Alzheimer's disease because that's where the data are clearest. Right now, 6.5 million. What do we have? We have pretty good tests for detecting Alzheimer's disease, and it's going to be getting better. We have very modest treatment for Alzheimer's disease. The drugs are not very effective. And we have tremendous need, but I would say we are lacking on support. And this support is either given through the healthcare system or the community. By 2030, 8 years away, it'll be up to 8.5 million. And what we're hopeful is that we will be able to identify risk factors, monitor, prevention, and then the detection, treatment, and support. The analogy here is to coronary artery disease. The biomarkers are basically to detect who's at risk, and that would be the equivalent of a cholesterol, serum cholesterol. They also might progress to actual having disease, which is mild cognitive impairment. And then the third stage is actually coronary artery disease, such as a myocardial infarction, which is the equivalent of dementia. Next slide, please. So as of 2022, here is the current management. First thing is acknowledge that this is a lifetime disease. There are no cures for dementia. Second is to play the ball where it lies. And if the disease is early, you want to try to include the person living with dementia, first of all, for decision-making and advanced care planning, but second of all, to decide whether they want to be in clinical trials, because that is an area in which we can have better hope for the future, that we will have drugs that will be effective in treating the disease. If it's late, then we need to rely on the families and caregivers. You want to aim for the highest level of independence that works for everybody. So, for example, if somebody wants to live at home, but it's completely destroying the entire lives of the caregivers and the family, it's not working for everyone. You treat the disease. The drugs that we have now are not very effective, but we use them. managing hot button issues like driving, staying at home, versus moving to some other more structured environment, managing the comorbidities, because that's what typically gets people in the hospital. It's much rarer for them to be hospitalized for behavioral disorders, although that does happen, but they typically get managed for other diseases, and manage the symptoms. Next slide, please. So caregivers. Caregivers are the most important resource a person with dementia has, and over half of these people develop depression. I always like to say that the more knowledgeable and the more empowered the caregiver, the better the care. And I always tell people that that it's not me as your physician or your dementia care specialist who is going to be the most important person in your life. It's going to be your caregiver. There are some effective training programs and support programs for caregivers, particularly REACH 2. This was mentioned in the NASTM report I issued last year or earlier this year. The NYU Caregiving Intervention and the Alzheimer's Association, many other community resources have caregiver training and support. Next slide, please. So the evidence for this, it has a small and moderate effect on knowledge, well-being, confidence, and self-efficacy. Also timed institutionalization, and that's an important outcome, and also behavioral symptoms. Barriers and limitations focuses only on the caregiver, and it's tested using traditional research designs rather than pragmatic designs. So this is an area where hopefully the NIA Collaboratory, Impact Collaboratory can help as well, but there's further research that needs to be done. But it's expensive, $250 to $500 a day for 6 months. So you're talking about $900 a year, perhaps. And typically these caregiver support groups are conducted in the community, so there's poor integration with healthcare systems. Next slide, please. So as a result, there are new models that have been developed for comprehensive dementia care that focus both on the patient and the caregiver. These tend to either be community-based, such as the BRI care consultation model, the Mind at Home model, the care ecosystem, or based in the healthcare system, such as the Indiana University Healthy Aging Brain Center, the UCLA Alzheimer's and Dementia Care Program, and the Integrated Memory Care Clinic. Next slide, please. Now, these share a lot in common. They're all comprehensive. They have continuous monitoring and assessment, ongoing care plans, psychosocial interventions aimed both at the person living with dementia and at the caregivers, self-management. Most have medication management, some of the community-based ones don't, treatment of related conditions, and coordination of care. These are the essential pillars of comprehensive dementia care. Next slide, please. Now, we're not going to have time to go into this in great detail, but the important thing here to recognize is that these models all differ a little bit. Who are the key personnel? What's the level of training? How much independence they have? Where are they based? Do they have face-to-face visit? Many of these programs are telephone only. Do they have 24/7 access? How do they communicate with the primary care providers? Are they able to write orders? And similarly, there are differences in benefits. Most of them improve quality of care when it's been measured. Patients and caregivers have shown benefit. The costs of the programs vary a lot, mostly because of labor cost of different personnel. And the amount of savings also is likely to differ. In some cases, have been demonstrated. Next slide, please. So why aren't these models everywhere? Why aren't all 6.5 million people receiving these kinds of models? Inertia and lack of insight. I remember a few years ago speaking to the head of a large managed care organization who said that they have 25,000 persons living with dementia that they know about. And here, 5 years later, they still have no formal dementia care program. Costs. The costs are upfront. You have to invest in the persons who are delivering the care upfront, and the savings such as reduced hospitalizations, reduced ED visits are downstream. If you are billing in fee-for-service Medicare, you can't make the hand work. The personnel are too expensive. You lose money on every patient. And if incentives aren't aligned, then savings may accrue to different stakeholders, so that the hospital may benefit, whereas the medical group may be paying the cost. Training of the providers, you don't learn this in medical school, you don't learn it in nurse practitioner training or PA training, so these people have to be retrained. Community-based partners, these are an essential component, but they're not all alike, so they have to be identified and vetted. And payment. There is no good stream of payment for community-based partners to provide the needed services. Next slide, please. So this is a pyramid. Not all persons living with dementia are created equal. This is 5,000 patients we looked at UCLA, and the top 1% were very expensive patients. They cost a minimum of $186,000 a year. Whereas the next tier, 2 to 5%, $65,000 per year. Next 15%, 6 to 20%, is $20,000 per year. And then you see at the bottom of the pyramid, it's very interesting. These people have mild dementia. Their families are coping at home pretty well. They don't cost a lot of money. And why would you think that the services needed for the top 1% or the top 20% would be the same as the bottom 80%? Next slide. So for that top 1%, you really want individualized care and very intensive with these comprehensive dementia care programs, advanced care planning and palliative care. Next slide. For that next 2 tiers up to 20%, top 20%, once again, high intensity programs, neurology consultations, psychiatry consultations, advanced care planning. Next slide, please. And then for those bottom 2 tiers, it's different. They need less intensive dementia care. They might be simply an information and referral system that is geared towards community-based resource. But the important thing is to monitor these people and as they make transitions to the higher stages, to employ those more intensive resources. So I am over, and I am going to stop here. Thank you very much. I'll stay on the line if there are questions, but otherwise I will turn it over.